Good morning, everyone. Welcome back to MedComplete Board Review. Our next case is a 42-year-old male with past medical history of rheumatic heart disease who presents to you for the complaint of palpitations that are intermittent and last 2 to 3 minutes. The patient has no other medical history and does not take any medications. His echocardiogram demonstrates normal ejection fraction with moderate mitral stenosis. EKG is shown below. Which of the following is the most appropriate choice for anticoagulation in this patient? Hey everyone, welcome back to MedComplete Board Review. So the answer to the previous question we posted regarding our 42-year-old male who has rheumatic heart disease is C. This patient should be placed on Coumadin therapy. So in order to get this question right, and this is the type of question that will definitely come up on some of your boards, we have to understand a few things. So the first important thing is to understand the EKG and to be able to interpret it and pick up that this is AFib. So for those of you on Instagram, if you slide your screen, you'll see a better form of the EKG. But for this, you have to understand that AFib is irregularly irregular with lack of P waves before the QRSs. So you can see there's clearly no P waves before any of the QRSs. And when we say irregularly irregular, we mean that the QRS, the distance between them is different, right? So if you could see clearly the distance between this and this is different, this and this is different. So that's irregularly irregular, and that means this is atrial fibrillation. So then the next step would be, well, if this patient has atrial fibrillation, does he require anticoagulation? So in a normal scenario, if this guy did not have rheumatic heart disease, his CHA2DS2-VASc score would be 0, right? He does not have hypertension, heart failure, history of TIA or stroke. He is a male. He's younger than 65. All of these criteria. So he would be 0, which would make him, the answer would have been in that case F. The patient is low risk for stroke and therefore does not need anticoagulation. So if you have every single point on the CHA2DS2-VASc score, and what CHA2DS2-VASc tells you is essentially what is the annual risk of stroke. So if we leave these patients off of blood thinners, per year, what is the risk of having a CVA? So if you have every single point on the CHA2DS2-VASc scale, your risk is about 15 to 17% per year, okay? Now, the thing that we want to understand is patients that have moderate to severe mitral stenosis, this by itself is an independent risk factor for stroke with AFib, and patients that have this have about a 15% risk of stroke per year, irregardless of everything else, if you don't give them anticoagulation. So patients that have AFib and severe or moderate mitral stenosis, regardless of the CHA2DS2-VASc, require blood thinners. And the blood thinner of choice is Coumadin, okay? It's not that the NOACs don't work, it's that they haven't been tested enough. We don't have enough data to say that they work appropriately. So for patients that have valvular AFib, which is patients that have moderate to severe mitral stenosis or AFib with a mechanical valve, those patients should be on Coumadin therapy. Non-valvular AFib, which means they don't have those two things, they can be placed on a NOAC, whether it's Xarelto, like rivaroxaban, Eliquis, etc. Okay. Aspirin by itself, usually you can give that for patients that have a CHA2DS2-VASc of 1. You can give them a low dose 81 aspirin. Dual antiplatelet does not work. It's been tested. It does not reduce risk of stroke enough and increases risk of bleeding. So the answer here is C. Okay, I hope you found this helpful, and please leave your comments and questions in the section below. Hey everyone, welcome back to MedComplete Board Review. Today we have a 29-year-old female with a past medical history of HIV who presents to you for the complaint of painful swallowing. The patient inconsistent with her HIV medication and states, "I take the medicine when I remember." Her current CD4 count is 66 with a viral load of 150,000 copies per ml. Physical exam is normal except for the following image. Which of the following is the most appropriate next step? Hey everyone, welcome back to MedComplete Board Review. I hope you're all having a great Labor Day weekend. So the answer to the previous question we posted regarding our 29-year-old female with HIV who has odynophagia is B. She should be started on oral fluconazole therapy. So in order to get this question right on the exam, we need to understand a few things. Anytime they give you an HIV patient on the exam who is immunosuppressed, meaning CD4 count less than 200, these patients, if they say, "I have painful swallowing," you should assume they have esophagitis. This is very important. This is an assumption that has to be made because the treatment is different. So, for example, if somebody just has oral thrush, but no odonophagia, they don't have any painful swallowing, they could be treated with simply nystatin, swish and swallow. But once they say, I have painful swallowing, or when food comes down, I feel a sensation in my chest, you have to assume that whatever is in their oral cavity has extended down to their esophagus. So if you see oral thrush in the mouth, you have to assume they have esophagitis secondary to Candida infection in the esophagus, okay? And therefore, the treatment would now, instead of being nystatin, if it involves the esophagus, you have to give them systemic therapy with oral fluconazole, okay? Nystatin does not work for esophagitis. It only works for oral thrush. So once it extends down deeper into the esophagus, you have to go with systemic therapy. Now, Candida is the most commonly tested because it's the #1 cause of esophagitis in HIV patients. But another question could have been if they showed you HSV, which is the #2 most common cause, if they showed you vesicular lesions in the mouth and the patient's describing pain while swallowing, then you would have to assume, again, whatever is in their oral cavity has extended down to their esophagus. So in that case, the answer would have been acyclovir. Okay. The third most common cause is CMV, and they tend to give you linear ulcerations, and obviously vanganciclovir will be the treatment there. But you know, that's less likely to be tested on your exam. It's more likely that you will have Candida or herpes being tested. IV micafungin is not a treatment of choice here. This is usually going to be for neutropenic fevers with candidemia. Then you can give them this. But in this situation, for all candidiasis, esophagitis, it doesn't do anything. Now, upper endoscopy is an answer that a lot of people generally pick, and there is a situation where this could be the right answer. So if the person, if this patient gets treated, let's say they have this picture, you give them diflucan or fluconazole, and the patient did not improve within 3 to 5 days, they don't have improvement of symptoms, then you should go in there and do an endoscopy to confirm that this is what they have, and you should do a biopsy as well to confirm the microbe that they have. The other situation where upper endoscopy would have been correct is if they have nothing in the oral cavity. So if the oral cavity is absolutely clear and this patient's complaining of dysphagia, you should do an upper endoscopy to confirm what the lesion is and the cause of that. And the treatment of choice. So it depends on what they give you on the test. If they give you an oral lesion that's obvious, then you can obviously jump straight to treatment. If the oral cavity is clear or the patient's resistant to treatment, then you go ahead and you scope these patients to confirm. Okay? I hope you found this helpful, guys. I hope you have a happy weekend, and if you have any questions, please leave them below. Welcome back to MedComplete Board Review. Today we have a 35-year-old female with a past medical history of spontaneous pneumothorax. She presents to the ER for chest pain and difficulty breathing. The chest x-ray in the ER reveals a spontaneous pneumothorax of the left lung. The patient is treated in the ER and stabilized. The patient has never smoked. She takes no medications. Due to the recurrent pneumothoraces, a CT of the chest was done. Which of the following is the most likely to be found in this patient? Hey everyone, welcome back to MedComplete Board Review. So the answer to the previous question we posted regarding our 35-year-old female with multiple pneumothoraces is C. Renal angiomyolipomas are the most likely thing to be seen in this patient. This question is a hard question, and it's one of the questions that people who score the highest on the medical board review SMLEs are usually going to get right. You need to know a lot of pieces of information here to get this question correct. So first and foremost, you need to know what the diagnosis is. So whenever they give you a CT of the chest, or they describe to you a young female who is a non-smoker and is developing multiple pneumothoraces with cysts all over her CAT scan, this is LAM, lymphangiomyomatosis, and the short term is LAM. So LAM occurs predominantly in females, and usually they're younger females of like premenopausal age, and they usually do not have a history of smoking. That's very important. And 1/3 of those patients present with spontaneous pneumothorax, because obviously these cysts that you can see here, all these air bubbles here, these obviously burst and they give the patients pneumo, and 1/3 of these patients, that's their initial presentation to us. The one thing you want to know about LAM is the same gene that causes tuberous sclerosis is the same gene that's a problem here. It mutated a little bit differently. So although due to the different mutation they get a different disease than tuberous sclerosis, the Extrapulmonary manifestations are the same as tuberculosis. So if you guys remember tuberculosis, they get cardiac sarcomas and then they get renal angiomyolipomas. The same thing you would see in LAM. So 1/3 of patients who have LAM will have renal angiomyolipomas at the onset of diagnosis. So the other thing they could have asked you is, what is the next step that you should do? You should go and ultrasound the kidneys or CAT scan the kidneys to look for these. Okay. These patients, obviously, their lung function deteriorates over time. The only drug that's approved for this is sirolimus. Interestingly, the same drug we would use in tuberculosis because it targets the similar protein, the mTOR protein. And here, the sirolimus is the only thing that's been shown to reduce the time of lung deterioration. Ultimately, these patients need lung transplantation. Okay, so going back to our answers, colon cancer, many things can give you colon cancer. Obviously, there's an entire list, but the most common on your exam tends to be like inflammatory bowel diseases, like Crohn's or ulcerative colitis. Endometrial carcinomas, the only genetic disorders that they generally test you on would be Lynch syndrome is usually a popular one that comes up a lot. Liver cysts are not found here, but they're found in adult polycystic kidney disease. Those patients can get liver cysts and pancreatic cysts. We'll do questions on each one of these later. So diabetes insipidus is here for a reason. It's a distractor. So the other disease differential here with these cysts is pulmonary Langerhans histiocytosis. So those patients also have cysts bilaterally, and they can present with pneumo, and they are predominantly in females. However, the distinction is that the cysts in the Langerhans tends to be thicker. I don't think they'll test you on that, but the difference clinically is that those patients are smokers, okay? Predominantly, 90% of them have a smoking history. So on the exam, the way you're going to differentiate LAM from pulmonary histiocytosis is the smoking history. So if they tell you that she never smoked, you're going to go with LAM. If she did smoke, you're probably going to go with pulmonary histiocytosis, okay? And the reason diabetes insipidus is here is because 20% of the histiocytosis patients have diabetes insipidus, okay? Breast cancer obviously has nothing to do with this. There are many conditions that give you that, like the BRCA gene mutations, etc. Okay, I hope you found this, guys, helpful. Please leave your comments in the section below, and please subscribe to our YouTube channel to support us, to keep us making videos like this for you in the future. Good morning, everyone. Welcome back to MedComplete Board Review. Before we begin, I just want to thank all of you for the support, and if you can please subscribe to our YouTube channel so we can keep this channel going, it would help us a lot. With that, today we have a 38-year-old female with no past medical history who presents to you for a checkup. The patient is an avid runner and plans on running the marathon in 3 months and wants to see if she is medically able to. She takes no medications. She runs about 2 miles daily and states she feels no symptoms. During your exam, you note a grade 2 out of 6 hollow systolic murmur on auscultation in the left fifth intercostal space. Carotid upstroke is normal. All other exam findings are normal. Vitals and EKG are normal. Which of the following is the best appropriate next step? Hey everybody, welcome back to MedComplete Board Review. So the answer to the previous question we posted regarding our 38-year-old female who is planning to run a marathon and has a hollow systolic murmur is A. She should undergo a transthoracic echo, okay? This type of question is very, very, very common on USMLE and on internal medicine boards. So it's very important that you know the details here, and sometimes the STEM kind of guides you away. So what I want you to concentrate on, so this question is literally asking, do you know the indications for echo in a setting of a murmur? Because not every murmur requires imaging, right? Some murmurs are innocent murmurs where they don't need to have any workup. So you will have something along the lines of this, and the most important aspect of whether it's going to happen is most likely going to be the auscultation findings, okay? So first and foremost, I think you all know this, any symptomatic patient with any murmur should have an evaluation of the murmur, regardless of the murmur quality, the grade, etc. Okay, so if they tell you that the patient, when she runs, she has significant symptoms with mild exertion, it's no-brainer, you get an echo, okay? However, if they give you something on the test that any diastolic murmur should be evaluated. So that's another indication that's important. So if they give you a diastolic murmur, that is pathological that needs to be evaluated, okay? So any diastolic continuous murmur, like that's indicative of like a PDA, and the reason why this patient needs it is because it's a hollow systolic murmur, okay? So any diastolic, continuous, hollow systolic, or late systolic murmurs should be evaluated with an echo, okay? Now, the grade also matters, so any grade 3 or above should also be evaluated, whether it's systolic or diastolic. But like let's say on your test, they give you a question that's a grade 2 out of 6, and they just say a systolic murmur, a soft systolic murmur, and nothing else. The patient does not need workup for that. That's reassurance, and you clear the patient. So they could give it to you in either way, all right? Obviously, murmurs that have a thrill or a carotid upstroke reduction, those patients also should get a transthoracic echo to further evaluate. So make sure you understand this very well and you go over it. It's very, very, very high yield, okay? I hope you found this helpful, and if you have any questions or comments, please leave them in the section below. Good morning, everyone. Welcome back to MedComplete Board Review. Today, we have a 32-year-old female with a past medical history of rheumatoid arthritis. She presents to you for the complaint of worsening joint pain and morning stiffness. The patient is currently on methotrexate for her disease, but her symptoms are not controlled and she has significant pain and swelling in all her MCP joints bilaterally. Her inflammatory markers are markedly elevated. Due to the severity, you consider infliximab therapy. The patient's agreeable to therapy. PPD is performed and is more than 15 millimeters. Chest X-ray is normal. The patient has no recent travel or exposure to any person with active TB. She has no symptoms. All other viral tests are negative. Which of the following is the most appropriate treatment approach? Hey everyone, welcome back to MedComplete Board Review. The answer to the previous question we posted regarding our 32-year-old female with rheumatoid arthritis is D. INH for 9 months, and she can start the infliximab therapy after 2 weeks of treatment. So this topic is quite important because infliximab and other TNF-alpha inhibitors are commonly used now for multiple indications in our fields. So we have to familiarize ourselves with the contraindications, what are certain things we have to look out for, the risks, the benefits, and be very familiar with that for the exam. So obviously you guys know infliximab is a TNF-alpha inhibitor. They could have just as easily put any other TNF-alpha here, so like etanercept. So familiarize yourself with the different types, okay, because any of them can come up on the exam. But what we have to know is that before we initiate these therapies, they're obviously very strong immunosuppressants. You have to make sure that the patient does not have active or latent tuberculosis, so that's what this question is about. You have to make sure that they do not have HIV, hepatitis B, hepatitis C. They should not have any active malignancies because this can worsen it, so those patients should have age-appropriate cancer screening prior to initiation of therapy, and they should be up to date on all their vaccinations, obviously, so that they don't get any sort of super infection that we can maybe prevent, okay? So as far as tuberculosis is concerned, if you have active TB, obviously that's a no-brainer. If they told you the chest X-ray here is positive with the PPD and the patient symptomatic, then that's definitely you don't give them infliximab. That's an active infection. But the common question that comes up is this: the latent TB question, where the PPD is positive but the X-ray is normal. Well, what do you do now? And for us, the cutoff for a positive PPD, just in case they put this on the test, is 10 millimeters. So it's 10 millimeters for TNF-alpha use. So I put 15 here, but it could have been just 10 would have been also positive. Or they could have given you, quantiferin gold, that would have been also positive, okay? So the important thing that you have to understand is these patients do not need to finish the full course of the latent TB therapy in order for you to initiate the medicine, okay? It's just as safe if you initiate therapy, give it about a week to 2 weeks, and as long as the patient is planning to take this therapy for the full time, then you can start infliximab after that time. One of the things that you have to understand, though, is TNF-alpha inhibitors, obviously they have a lot of side effects, but they're also hepatotoxic, and INH is hepatotoxic. So these patients, once you put them on this regimen, they have to come and get liver function testing every month, okay, to make sure for the duration of therapy that they're on the latent TB. I want you to also understand that INH for 9 months, obviously combined with B6 to prevent the neuropathy, is not the only option here. They could have easily given you any other treatment options for latent TB. So they could have said, 9 months of INH, 4 months of rifampin. They could have given you 3 months of once weekly INH and rifapentin. So please familiarize yourself with the treatment options for latent TB because they can all be here. INH is the most commonly present on your exam, but doesn't necessarily have to be there. It could have been another treatment option. Okay, don't fall for this trap. A lot of people pick C. They think that you have to completely treat the disease first, then you can start the infliximab. That there's no difference if you already are on treatment and you start infliximab. The data is pretty equivalent that they do not reactivate as much, as long as the patient is consistently taking this. And obviously this is wrong. They are a candidate if you treat them appropriately, and as long as you just make sure that you're monitoring these patients with liver function testing, they should do okay. All right. I hope you found this helpful, guys, and hopefully you get it right on the test. And I'll see you in the next question. Hey everyone, welcome back to MedComplete Board Review. Today's case is a 24-year-old male with a past medical history of seizure disorder and idiopathic cardiomyopathy who presents for increased depression. The patient states he was recently started on Sertraline for depression. His depression has improved slightly and he has been on Sertraline for 6 months. He also states that he now has difficulty with erections and this has caused him great stress in his relationship. He has been seizure-free for the past 1 year and is not taking any medications at this time. Physical examination is normal. Which one of the following is the most appropriate? Hey everyone, welcome back to MedComplete Board Review. So the answer to the question we posted before regarding our 24-year-old male who has a history of seizure disorder, cardiomyopathy, and depression is F. The patient should be switched from sertraline to mirtazapine. So this type of question is very typical on both USMLE and internal medicine boards. So we have to familiarize ourselves with the different antidepressants that should be used, when are they indicated, when are they contraindicated, and their side effect profile. So sertraline is one of the most commonly used antidepressants. It's an SSRI, and one of the main side effects that it can potentially cause is erectile dysfunction, delay in ejaculation. So in these patients that experience these side effects, if they don't have an initial significant improvement in their symptoms, they should be switched off of this drug and ideally switched to either another SSRI, or more commonly they should be switched to bupropion. Okay, so bupropion is Wellbutrin, okay, and it's one of those drugs that's used that does not cause significant erectile dysfunction. It also doesn't cause significant weight gain, so sometimes you can use it in that situation. The reason why it's not the right answer here is because the patient has seizure disorder, and bupropion is known to lower the seizure disorder. Now, there are long-acting forms of bupropion that have less increase in seizures, but that's not going to be tested on your exam. I don't think they'll have you separate the two. Most likely they'll just have bupropion there. So just for the purposes of your test, I would not give bupropion to anybody that has seizures. Just make sure you do not make this mistake. Switching from sertraline to another SSRI sometimes is a good idea, but paroxetine is the only option listed here that's an SSRI, and paroxetine is by far the most likely to cause erectile dysfunction. Okay, the way you can remember it is P for penile side effects. So this one is not the one you want to give if somebody has these effects. It will make it worse. Amitriptyline is another reasonable option. However, in this case, we do not give TCA inhibitors to anybody that has cardiomyopathies or any conduction delays. Okay, so amitriptyline in these patients can induce AV blocks, it can induce conduction delays, it can affect vascular resistance, so it's really not a very good idea to give this to patients that have cardiomyopathies. Just do not get this wrong on the test. This is something that a lot of people sometimes pick, or bupropion, and you want to be sure that you understand when they are contraindicated. Okay, mirtazapine does not lower seizure threshold, and it's not contraindicated in cardiomyopathies. So this is going to be your go-to, okay, in this case, all right? But if they gave you a different question where the patient did not have seizure disorder, okay, then you would go for bupropion. Bupropion is probably the better option, but if they do have seizures, do not fall for this trap. Don't pick this. And if they have any cardiac issues, do not give them TCA. All right, I hope you found this helpful. Get it right on the test, and I'll see you for the next question.